Assalamualaikum. This is Dr. Haseeb. Can you hear me? Assalamualaikum. क्या आप सुन सकते हैं मुझे? प्लीज बताइए.
जी सर, लेक्चर स्टार्ट करें.
Okay, thank you. Assalamualaikum everyone. Hope you are fine. Today we are going
सर
to discuss a very important topic, that is electroencephalography.
देखने करें. ओके सर.
So by the end of today's session, inshallah, you will be able to define electroencephalography. What is the clinical significance of electroencephalography, and what are the different types of brain waves or EEG bands. So these are the learning outcomes for the today's session. So let's begin. So before jumping to the EEG, I would like to re-emphasize the importance of the stages of sleep. As we have discussed earlier, that sleep can be divided into two major categories. The first stage is the non-REM stage, that is non-rapid eye movement stage. The second stage is REM stage, where REM stands for rapid eye movement stage. Non-REM stage is subdivided into four stages, where the first two stages of non-REM are known as the light sleep, and the last two stages, stage 3 and stage 4, they are known as the deep sleep or slow wave sleep. The other name for deep sleep is delta sleep. So these are the two stages of sleep, non-REM and REM. In non-rapid eye movement stage, the EEG pattern is synchronized. So the brain waves are in harmony. They are in a synchronized pattern. That is why we can call it as synchronized sleep. REM sleep, on the other hand, is known as desynchronized sleep because the EEG pattern is asynchronous. So the EEG pattern of a patient or a subject during REM sleep is almost similar to that of a awake person. Pattern is similar to that awake person. That is why we can call it as paradoxical sleep. And these are the important differences between the two types of sleep: non-REM, slow wave sleep, and paradoxical sleep or REM sleep. As the name indicates, non-REM sleep is the part of the sleep in which there is no extraocular movement. And in REM sleep, there is extraocular movement or rapid eye movements. The thing to remember is that the EEG pattern of REM sleep is very similar to a person who is alert, a person who is awake. So this is a paradox. Although the person is in sleep, but the EEG is similar to that of awake person. Moreover, paradoxical sleep or REM sleep occurs at regular intervals. So there are multiple episodes which occur at a regular interval. For example, episode is repeated after 90 minutes. Although the REM sleep comprises of almost 20 to 25% only of the total duration of sleep, but this 20 to 25% occurs at regular intervals, usually after about 90 minutes. So after every 90 minutes, REM sleep will be followed. Another important feature of REM sleep, besides the rapid eye movement, is that all the physiological parameters are fluctuating. For example, the heart rate or the pulse rate, respiratory rate, as well as the arterial pressure. All these CVS parameters, they are irregular. So you may see fluctuations in these parameters, unlike slow wave sleep or non-REM sleep, in which there is no significant fluctuation in these parameters. So this is yet another difference between the two types of sleep. Moreover, dreams are more common in REM sleep, whereas non-REM sleep is usually dreamless sleep. And unlike REM sleep, the non-REM sleep is subdivided into 4 stages. Stage 1, 2 are the light sleep, and stage 3 and 4 are the deep sleep or delta sleep. Again, you can differentiate. These are the differences between the two types of sleep. We have discussed few of the differences already. Another difference is in the autonomic function. So as far as the autonomic nervous system is concerned, the parasympathetic division of ANS is dominant in the non-REM stage, whereas in REM sleep there is fluctuation. But overall, again the parasympathetic system is the dominant. Moreover, there is reduction in the metabolic rate in either stage, whether REM or non-REM. The basal metabolic rate is reduced, although there is slight anabolism in non-REM. So during REM sleep, the limbic system is slightly active as compared to the one experiences dreams during the REM episodes. So again, REM sleep is characterized by rapid eye movements. REM sleep is characterized by frequent dreams, and there is muscle twitching. Although the muscle tone, skeletal muscle tone is on the lower side, but there is muscle twitching. So these are the three features of REM sleep. All these features are absent in non-REM sleep. Then the physiological parameters like heart rate, arterial pressure, respiratory rate, and these are the vital signs: heart rate, arterial pressure, body temperature, and respiratory rate. These vital signs are irregular in REM sleep. So the vital signs, they remain stable during most of the non-REM stage. So to summarize, sleep is divided into two stages, subdivided into 4 stages, stage 1 to 4. Stage 1 and 2 of non-REM are the light sleep. Stage 3 and 4 of non-REM are the deep sleep. REM sleep, although comprises only 25% of the total sleep duration, but is repeated after every 90 minutes. And this is characterized by rapid eye movements, dreams, muscle twitching, and fluctuation in the vital signs. Now we will move to the electroencephalography. So the German psychiatrist Hans Berger was the one who introduced this procedure, this process of electroencephalography or electroencephalography. Both pronunciations are correct. And why do we perform EEG? What is the clinical significance? So, what is EEG? Electroencephalography, as the name indicates, it is the graphical representation of all the electrical activities which are occurring in the brain. And these electrical events are represented on a graph paper, and the paper is known as electroencephalogram. So we can perform EEG to localize any pathological phenomenon. For example, this is used for diagnosis and localizing hematomas within the brain, like subdural hematoma. Any lesion within the cerebrum can be localized, but the most significant or the most important use of EEG is its role in epilepsy, or you can say monitoring of seizure activity. So the patients of epilepsy, they usually undergo EEG. So in your first year MBBS, you must have learned the procedure of electrocardiography by different electrodes over the limbs and electrodes over the precordium. This is the electrode placement for electroencephalography, and this system is known as the 1020 system. So this is a standard system, 1020 system, where 1020 stands for the distance between two adjacent electrodes which are placed over the skull is either 10% or 20% of the total skull distance. For example, this is the superior view of the scalp or skull. On either side, you can see the auricle. This is the left auricle here, denoted by A. This is the left side, and on the right side, you can see the right auricle or the right ear, A2. And these circles, they indicate the exact location for the multiple electrodes that we have applied. This is the anterior portion, this is the nasion, and this is the posterior portion, the inion, which is the occipital protuberance. So nasion placed anteriorly, inion is the posterior end, and this is the midline. Here you can see the midline or the sagittal line, which runs vertically over the skull, and this is the ground electrode that you have placed over the center of the skull. So C stands for the central electrode. So you have placed the central electrode at the center of the skull. So this is usually the ground electrode. Now you can see different letters on either side of this sagittal plane. The F electrodes are the frontal electrodes, the T electrodes are the temporal electrodes, P for parietal, and O for occipital. Another thing to consider is that you have placed the even number electrodes on the electrode. You can see F1, F3, F7. The odd number frontal electrodes are placed on the left side, and the F2, F4, F8, the even frontal electrodes are placed on the right side. Same is the case for temporal, parietal, and occipital electrodes. So you apply electrodes over the surface of the skull. and then you monitor the REM sleep. The procedure is known as electroencephalography, and the graph that we interpret, whether on the EEG paper or on an oscilloscope screen, is known as electroencephalogram. And what is the mechanism behind electroencephalography? For that, you have to understand the concept of a dipole. So, what is a dipole? A neuron which acts as a dipole or a bipole. So, here is a neuron. This is a neuron from the cerebral cortical area. You can see the cell body or the soma. This is the cell body. This is the axon. And here you can see this tree like structure. These are the dendrites. So these are the dendrites. So the dendrites and the cell body, these act as two different electric poles. That is why we can call it as a dipole or a bipole. So when the sum of the dendritic activity here is negative as compared to the soma of the neuron, this will lead to depolarization. Similarly, when the sum of dendritic activity is positive as compared to the cell body, this will lead to hyperpolarization. So these are either depolarization or hyperpolarization. Remember, electroencephalogram is representation of graded potential. These are post-synaptic potentials. Remember, these are not action potential. So either the neuron is in a depolarized state or in a hyperpolarized state. So the dendrite and the cell body, they act as two different poles. One act as positive and the opposite will act as negative. And this is known as the electroencephalogram, the graphical representation of the electrical activities which are occurring within the brain. So you can see this is the awake stage, then comes the rapid eye movement stage, followed by the non-REM stage. So these are the stages of non-REM stage. Stage 1, 2, 3, and 4, the stages of non-REM. And different types of EEG bands are observed. The first one is the beta waves. As you can see, beta waves are observed in an alert, awake person. As you can see, these are low voltage waves. Beta waves are low voltage. The amplitude is very low and there is no rhythm to it. So this is known as asynchronous wave pattern or desynchronous wave pattern. And if we compare the beta waves with the alpha waves, here you can see the alpha waves are much more stronger in amplitude or voltage, and there is a particular rhythm to it. And these alpha waves are observed in a person who is awake but quiet. So during quiet, calm, resting state of wakefulness, alpha waves are observed. So beta waves are not only observed in an alert, awake person, but the same wave pattern is observed in the REM sleep. That is why we call REM sleep as paradoxical sleep. So this REM sleep will be followed by the four sub stages of the non-REM, starting from the sleep spindle wave pattern, theta wave pattern, and delta wave pattern. Again, you can compare the amplitude as well as the frequency of all the different EEG bands. If you compare alpha wave with beta wave, you can appreciate that alpha waves are synchronized. Alpha waves are synchronized. The amplitude is much greater, and the beta waves are desynchronized wave. There is no rhythm to beta wave pattern, and the amplitude is relatively smaller as well. Theta wave and delta waves both are observed in non-REM sleep. Delta waves are frequently observed in stage 3 as well as stage 4 of non-REM sleep. That is why the last two stages of non-REM sleep, stage 3 and stage 4 sleep, are known as the delta sleep or deep sleep. And these delta waves are of larger amplitude. Now we will discuss the phenomenon of desynchronization. Now, what do we mean by the term desynchronization? In simple words, this is replacement of alpha waves with beta waves. So alpha waves are replaced by the beta waves as soon as you open your eyes. Here you can see, as soon as you open your eyes, this alpha wave pattern, this is the alpha wave pattern. This pattern is rhythmic, synchronized, and of larger voltage. This alpha wave pattern is instantaneously replaced by the low amplitude desynchronized beta wave pattern. So opening or closure of eyes will determine the EEG pattern. So when you open your eyes, alpha waves are replaced by beta waves. And when you close your eyes, again beta wave pattern will be replaced by the alpha ones. And this replacement of alpha wave pattern with desynchronized low voltage beta wave pattern is known as desynchronization. Again, you can see this is the alpha wave pattern. The alpha waves are usually observed when you close your eyes. They are rhythmical, they are synchronized, they are of larger voltage. And when you open your eyes, this is replaced by the beta wave pattern. As you can see, beta waves are of low voltage, the amplitude is much smaller, and there is no significant rhythm to it. That is why this pattern is known as desynchronized pattern. And replacement of alpha wave with beta wave when you close your eyes is known as, sorry, when you open your eyes is known as desynchronization. The other name for desynchronization is alpha block. Alpha block or desynchronization, both are the same thing. Sometimes we can call it as the arousal response or the alerting response. Now, this figure is taken from Ganong's review of medical physiology. Here you can compare different type of EEG bands in different states of mind. During awake state, you can observe the EEG pattern. Then during the light sleep, and at the end during the deep sleep. And you can appreciate the frequency as well. So the frequency during the awake state, the frequency is 20 to 80 hertz, where 1 hertz is equal to 1 cycle per second, whereas the frequency drops to 7 to 15 in the light sleep stage, and further drop to zero point 0.5 to 4 hertz in the deep sleep state. That is stage 3, stage 4 of non-REM sleep. These are the deep sleep stages. So you can appreciate drop in the frequency from 20 to 80. It drops to 7 to 15 during the light sleep, and it is almost close to zero point 0.5 during the deep sleep. And the cerebral cortical neurons are connected with the thalamic neurons through a pathway known as the thalamocortical loop. Remember, there are specific neurons which connect the cerebrum to the thalamus. So the cerebrum is connected with the thalamus through specific pathway through specific neurons. The pathway is known as thalamocortical pathway or the thalamocortical loop, and the neurons are known as the thalamocortical neurons. And this is the pattern of firing of action potential by the thalamocortical neurons. So you can see during the awake state, the thalamocortical neurons, they are rhythmically firing action potentials, and these are known as tonic firing potentials. So they are rhythmically firing action potentials at a regular interval. Similarly, during the light sleep and the deep sleep, you can appreciate bursts of firing. So these are the bursts of electrical activity that is thrown by the thalamocortical neurons, especially during the light sleep and deep sleep. So tonic firing during the awake state, and bursts of electrical activity during the light sleep and deep sleep. So the thing to remember is the frequency from the awake state to the light sleep drops from 20 to 80 to 7 to 15, and further drops to zero point 0.5 during the deep sleep. Moreover, the thalamus and the cerebrum, they are connected with each other through a pathway known as the thalamocortical pathway or the thalamocortical loop. And these are specific neurons which are responsible for this connection. The neurons are known as the thalamocortical neurons. Again, you can compare the three types of electrical patterns. The one on the bottom is the EEG that we have just discussed, electroencephalogram. The one in the middle is the muscle activity known as the electromyogram, and the one on the top is the electrical activities within the extraocular muscles. This is known as the electrooculogram. So electroencephalogram is the graphical representation of electrical activities of brain. Electromyogram is the graphical representation of electrical activities of the skeletal muscle, and electrooculogram is the graphical representation of electrical activities in the ocular muscles. So here you can observe EEG with EMG and EOG. And these are the stages of sleep. We start with the non-REM sleep. This is the non-REM sleep. As you can see, the non-REM is subdivided into four stages: stage 1 to stage 4. And this non-REM will be followed by an episode of REM. This is REM sleep. Remember, REM sleep only comprises of 25% of the total sleep duration, but this occurs in regular episodes, usually after about 90 minutes. And here you can observe the EEG pattern in each of the four non-REM sleep stages as well as in REM sleep. The REM pattern, as you can see, is very similar to that of a person who is awake. So this is the pattern of an awake person, and this is the pattern of a person who is in REM sleep. So you can appreciate both are very similar to each other. This is the beta wave pattern during the REM sleep. So beta wave pattern is observed not only in the alert awake person, remember, alert awake person, as well as in REM sleep. So that is why we call it as paradoxical sleep. You can see the pattern is desynchronized. This is irregular and the voltage is much lower. If you compare this wave pattern with the deep sleep, you can see the voltage difference between the two. This is the delta wave pattern in stage 4. Here you can see in stage 4 and in stage 3 of non-REM, this is the delta wave pattern. These are delta waves. These are delta waves. Delta waves are observed in stage 3 and stage 4 of non-REM sleep. And you can appreciate, you can compare the voltage of these high amplitude delta waves with the low amplitude beta wave. So this is beta wave, beta. Beta is observed in REM sleep as well as in an alert awake person. Stage 3 and 4 of non-REM are characterized by delta waves. As far as the stage 2 of non-REM is concerned, this unique EEG pattern is known as the K complexes or sleep spindles. These are K complexes or sleep spindles. We will discuss what are K complexes and sleep spindles at the end of the discussion, inshallah. Now, this is another electroencephalogram starting from the alpha wave, drowsy state, followed by the non-REM sleep, the 4 stages of non-REM. This is non-REM, this is non-REM sleep. And at the end, we have REM sleep. So you can differentiate the differences between. So alpha waves are observed in drowsy state, beta waves are observed in REM sleep as well as in an alert awake person. Delta waves are commonly observed in stage 4 of non-REM. Here you can see the amplitude is significantly larger as compared to beta waves and alpha waves. That is why stage 3 and stage 4 of non-REM is also known as delta sleep. And these are the sleep spindles. Here you can see sleep spindles are bursts of electrical activity. Here you can see sleep spindles are bursts of electrical activity. Here you can see high frequency burst of electrical activity followed by a large wave. And this large amplitude, large high voltage wave is known as K complex. So sleep spindles are followed by large amplitude K complex. Sleep spindles are bursts of high frequency electrical activities, as you can see here. K complexes are characteristic features of stage 2 of non-REM sleep. And stage 1 are characterized by theta waves. Theta waves are of relatively low voltage and medium frequency. So this is the distribution of sleep stages among children. among young adults, and among elderly patients. And these shaded boxes, these shaded regions, they indicate the REM duration of REM sleep. And you can compare that children have more total sleep time as well as more REM duration as compared to young adults. On the other hand, young adults have relatively greater total sleep time as well as REM duration as compared to elderly person. So this means there is variation with age. Side of your system are level which decrease with age. For example, sleep efficiency is decreased with age. Rapid eye movements are not as frequently observed as we observe in young people. Similarly, elder patients or elderly people have a tendency of frequent naps, especially during the daytime. The sleep latency is also increased with aging, and more frequent arousals, more frequent awakenings are observed in elderly people as well. So these are the variables that either increase or decrease with age. Again, you can observe the alterations, the variations in sleep pattern as we age. The amount of REM sleep is compromised. Remember, infants and children, they have highest amount of REM sleep as compared to young people. And young people have relatively greater amount of REM sleep as compared to elderly. So as we age, the amount of REM sleep progressively decreases. Moreover, tendency to develop sleep disorders is much higher in elderly people as compared to young people or children. Moreover, the sleep efficiency is compromised. Sleep efficiency or quality of sleep is compromised. And the frequency of day naps is increased. Remember, daytime naps, the tendency to take naps is increased in elderly people. So these are the variables that we may observe as we age. Now this is the last slide of the session. I would like to request the students to take some notes. This is very important for your examination point of view as well. So now we are going to compare and contrast different types of EEG bands or different types of brain waves in both REM sleep as well as in non-REM sleep. So the first type of EEG wave that we observe in a person who is awake but relaxed. So in a person who is awake but relaxed with eyes closed, remember, in a person who is awake but relaxed with eyes closed, the pattern observed will be the alpha wave pattern. This is the alpha wave pattern. So remember, alpha is observed in awake person but relaxed. And you can see the amplitude is slightly higher, 50 to 100 microvolts. Remember, the easiest way to denote amplitude is in microvolts. We can express it in millivolts, but the easiest unit is microvolt. And frequency or cycles per second are usually represented in hertz, where 1 hertz is equal to 1 cycle per second. So the frequency is 8 to 13. So remember, this alpha wave pattern is synchronized pattern as compared to the counterpart beta wave pattern. This alpha wave pattern is synchronized, and this is usually recorded from the parietal and frontal and occipital areas. So the most intense alpha wave pattern are usually observed from the occipital lobe, but parietal lobe and frontal lobe they can also observe. We can also observe this alpha wave pattern from these regions as well. So alpha wave pattern is observed in a person who is awake but relaxed. So when you close your eyes, the pattern that we will observe is alpha wave. And when you open your eyes, you will observe beta wave. Now comes the non-REM sleep. As we have discussed earlier, non-REM is subdivided into four stages. So this is the stage one, the first of the four stages. And the characteristic of stage one non-REM sleep is existence of theta waves. Remember, these EEG waves are denoted by Greek letters. So theta waves are observed in stage 1 of non-REM sleep. And the frequency, if you compare it with the alpha wave, is slightly less. And the voltage, the amplitude is extremely low. So these are low voltage, low frequency wave pattern usually observed in light sleep or drowsy sleep. That is the stage 1 of non-REM sleep. Moreover, if we consider the lobes of the cerebrum, the parietal and temporal regions are the ones. Moreover, theta waves are usually observed in children, in emotional states, or in psychomotor states. So these are the characteristic of the theta wave band. The next stage is the stage 2 of non-REM sleep. Stage 1 and stage 2 of non-REM sleep are collectively called as light sleep. Remember, stage 1 and stage 2 of non-REM are collectively known as light sleep. The last two stages of non-REM 3 and 4 are the deep sleep. But the EEG wave pattern in the first two stages of light sleep are different. We have discussed the theta wave pattern in stage 1, low frequency, low voltage. But the EEG wave bands are unique in stage 2 of non-REM, and these are known as sleep spindles and K complexes. We have discussed earlier, I have shown you the graph as well. Sleep spindles and K complexes. Sleep spindles are sinusoidal waves. These are high frequency bursts of activity. So these are high frequency bursts of the voltage is low, remember, but the frequency is high. Low voltage, high frequency bursts of activity. And this is usually followed by a low frequency, high voltage curve known as the K complex. So the frequency is low, the amplitude is very high. Remember, the amplitude is almost close to 100 microvolts. sorry for the interruption. We were discussing the EEG wave pattern in stage 2 of non-REM sleep, and we have discussed stage 2 of non-REM is characterized by two types of EEG bands, sleep spindles and K complexes. Sleep spindles are high frequency, low voltage bursts of activity. High frequency, low voltage bursts of electrical activity. And this is usually followed by a low frequency, high voltage biphasic curve. Remember, the voltage is almost close to 100 microvolts. So the K complex is of larger amplitude. Then we discuss the biphasic nature of K complexes. By biphasic nature of K complex, we mean that half of the curve is above the isoelectric line and half of the curve is below the isoelectric line. This means half of the deflection is positive and half of the curve shows negative deflection. So the K complexes are biphasic, and both these EEG bands, sleep spindles and K complexes, are observed in stage 2 of non-REM. Then comes the deep sleep or delta sleep. Remember, when we use the term delta sleep or deep sleep, we are referring to the last two stages of the non-REM, that is stage 3 and stage 4. And why we call it as deep sleep? Because we observe delta wave pattern, and the delta wave pattern are of low frequency. You can see the frequency is almost close to zero point 0.5 hertz, but the characteristic feature of this delta wave is its high amplitude. So if you compare the amplitude of delta wave with the rest of the wave, you can see a significant difference. So the amplitude can rise as high as close to 200 microvolts. And remember, this delta sleep is deep sleep or dreamless sleep. So remember the three D's. Remember the three D's. Delta wave is deep sleep and delta wave is dreamless sleep. Now this non-REM will be followed by an episode of REM sleep. So this is usually followed after every 90 minutes. So in REM sleep, we observe beta wave pattern. Moreover, the same pattern or similar pattern is also observed in a person who is fully awake and fully alert. That is why we call REM sleep as paradoxical sleep, because the sleep pattern during REM sleep is similar to that of an alert awake person. So remember, beta for brain. So when you use your brain, when you use your brain activity, the EEG wave pattern will be beta type. And this beta wave, if you compare with the alpha wave, these are asynchronous or irregular. So asynchronous nature of beta wave, whereas alpha waves are rhythmical or synchronous in nature. So this is one of the differences between the two types of waves. Alpha waves are synchronized, beta waves are asynchronized or desynchronized. Moreover, the amplitude is much lower, much lower as compared to the alpha wave. So you can see the amplitude of alpha wave can rise as high as close to 100 microvolts, and the amplitude for beta wave is close to 5 microvolts only. Although the amplitude is much smaller, but the frequency is much larger. So the frequency is much larger as compared to the low frequency alpha waves. So these are the differences between alpha waves and beta waves. In your Viva exam, most of the examiners like to differentiate the two types of EEG patterns: alpha wave pattern and beta wave pattern. So remember, alpha wave pattern is observed in an awake person who is relaxed with eyes closed, whereas beta wave pattern is observed either in an awake person who is alert or in a person who is in REM sleep. Moreover, alpha waves are high voltage, low frequency waves. Beta waves are low voltage, high frequency waves. Alpha waves are synchronized rhythmical waves. Beta waves are asynchronized or irregular waves. And last is the gamma wave band or the gamma band. So the controversy is that gamma waves are almost similar to beta waves, but sometimes we can classify them as separate EEG band. And these gamma wave oscillations are usually observed in a person who is aroused and whose attention is focused. Remember, the frequency of gamma oscillations is highest, so fastest frequency and smallest amplitude. And these are known as gamma oscillations. So gamma oscillations are high frequency, low voltage oscillations or waves that are observed in a person who is aroused and whose attention is focused. So this is all for today. Today we discussed electroencephalography. Electroencephalography is the procedure in which we record the electrical activities of the brain by placing different electrodes over the surface of the skull. And the graph that we obtain over the paper strip or over the oscilloscope screen is known as the electroencephalogram. We use this electroencephalogram to record the EEG wave pattern in patients of epilepsy or seizures. We can localize lesions within the cerebrum with the help of this procedure. We can localize hematomas like subdural hematoma with the help of this EEG. And then we discuss different types of EEG bands that are observed in either non-REM sleep or REM sleep. So the most important are the alpha waves and the beta waves. Alpha waves are observed in an awake person who is quiet with eyes closed, and beta waves are observed in a person who is either in REM sleep or who is awake and fully alert. So the wave pattern in a person who is in REM sleep is almost identical to that of an alert awake person. That is why we call this REM sleep as paradoxical sleep. So this is all for today. Thank you very much. Allah Hafiz.
Assalamu alaikum ji. This is Dr. Harun Habib from the Biology Department of Avicenna Medical College. Can everyone hear me and see me fine? By see me, I mean see the slides.
अस्सलाम वालेकुम सर।
जी जी
सर
वालेकुम अस्सलाम।
लेक्चर स्टार्ट करें सर, टाइम हो गया, बोल नहीं रहे, हम परेशान हो गए, पता नहीं क्या हो गया आज।
नहीं जी परेशान नहीं हो।
ओके सर।
Alright ji, the topic we were discussing was biochemistry of endocrine system. हमने स्टार्ट किया था pituitary and hypothalamic hormones. जो आप लोगों के टॉपिक्स थे इस pituitary और hypothalamic hormones के वो कुछ इस तरह थे। यहाँ तक एक्रोमैगनी तक करके हम लोगों ने मैंने थोड़ा सा आप लोगों का चेंज किया था। ACTH एड्रेनोकॉर्टिकोट्रोपिक हार्मोन निकाल के आपने डायरेक्ट ADH हार्मोन्स या डायूरेटिक हार्मोन है वो शुरू किया। ACTH मैंने आप लोगों का निकाला, ये हमने नेक्स्ट टॉपिक में करना है। पिट्यूटरी हार्मोन्स के हार्मोन है ADH एंटी डायूरेटिक हार्मोन, इसको कल हम लोगों ने शुरू किया था। कल आई मीन डे बिफोर यस्टरडे। उसके कुछ डिसऑर्डर्स एंड डायबिटीज इंसिपिटस और सिंड्रोम ऑफ इनएप्रोप्रिएट AGS सेक्रेशन। Diabetes insipidus is a condition characterized by large amount of dilute urine and increased thirst, resulting from the deficiency of ADH. and characterized by passage of copious amount of dilute urine. Can nearly be as much as 20 liters per day. The two types of diabetes insipidus, central diabetes insipidus and nephrogenic diabetes insipidus. Central जैसे नाम से जाहिर है कि there must be some pituitary disorder. Nephrogenic, there must be some kidney disorder. The central diabetes insipidus is due to the failure of pituitary gland to secrete adequate ADH. And nephrogenic results when the renal tubules of the kidney fail to respond to the circulating ADH. Signs and symptoms of diabetes insipidus are common for both central and the nephrogenic type. Polyuria, polydipsia, thirst, nocturia, nocturnal anuresis, hypernatremic dehydration, anorexia, constipation, hyperthermia, and lack of sweating. The etiology of central diabetes insipidus is tumors, infections, trauma, and leukemia. This is an illustration of the central diabetes insipidus. So you can see on the left there is a normal secretion of ADH from the pituitary, and that ADH being acting on the kidneys produce a normal amount of urine. On the right you can see the ADH secretion stops from the pituitary, so no ADH acts on the kidney and results in a copious amount of production of urine. The etiology of the nephrogenic diabetes insipidus is divided into two, primary and secondary. Primary may be familial. Secondary is chronic pyelonephritis, a kidney disorder, hypokalemia, hypercalcemia, sickle cell disease, or protein deprivation. In this illustration, on the left, you can see normal production of ADH from the pituitary, and this dispersion in the body and action on the kidney, resulting in the formation of normal amount of urine. On the nephrogenic side, on the right side of the picture, you can see normal production of the ADH from the pituitary, distribution across the body, but the kidneys fail to acknowledge the presence of the ADH, resulting in the production of an copious amount of urine. So this is it for the diabetes insipidus. Our next topic is syndrome of inappropriate ADH secretion, SIADH. In this, the body makes too much ADH. What was the problem in diabetes insipidus? The body either was not producing ADH or the kidneys were not able to acknowledge the ADH. But here, the body makes too much ADH. This hormone helps the kidney control the amount of water your body loses through the urine. So SIADH causes the body to retain too much water. आप लोगों को परसों भी एक चीज बताई थी, ADH ज्यादा होगा तो बॉडी में वाटर कंटेंट ज्यादा होगा, ADH ज्यादा होगा तो यूरिन में वाटर कंटेंट कम होगा. एडीएच कम होगा तो बॉडी में वाटर कंटेंट कम होगा, एडीएच कम होगा तो यूरिन में वाटर कंटेंट ज्यादा होगा। यहाँ पे एडीएच ज्यादा है तो बॉडी में वाटर कंटेंट ज्यादा होगा, यूरिन में वाटर कंटेंट कम होगा। It's characterized by excessive unsuppressible release of ADH either from pituitary gland or an abnormal non-pituitary source. जो ADH की सिक्रीशन है वो अनसप्रेसिबल है और एक्सेसिव है, या तो जो सोर्स है सिक्रीशन का या तो वो पिट्यूटरी ग्लैंड है या वो नॉन पिट्यूटरी सोर्स। अल्टीमेटली हमारी बॉडी में एडीएच की सिक्रीशन ज्यादा है, दैट्स व्हाट इज द प्रॉब्लम। The unsuppressed ADH causes an unrelenting increase in solute-free water. Unrelenting increase in solute-free water being returned by the tubules of the kidney to the venous circulation. Solute-free water absorb हो रहा है दोबारा ट्यूब्यूल से, वो venous circulation में continuously जाता जा रहा है due to the presence of excessive ADH. क्या रिपीट करना बेटा? या नलायकी तेरा ही आसरा। करता हूँ रिपीट, मुझे ये जरा SIADH खत्म कर लेने दें। The causes of syndrome of inappropriate ADH secretion: primary brain injury, infection, hypothyroidism, malignancy, and some drugs. All of these causes an increased secretion of ADH. Increased secretion of ADH means increased water retention in the body. Differences between diabetes insipidus and SIADH. डायबिटीज इंसिपिडस में हमारे पास हाई यूरिनरी आउटपुट थी, SIADH में लो यूरिनरी आउटपुट है। डायबिटीज इंसिपिडस में हमारे पास लो लेवल्स ऑफ ADH थे, SIADH में हाई लेवल्स ऑफ ADH। डायबिटीज इंसिपिडस में हमारे पास हाइपरनेट्रीमिया हो सकता था, SIADH में हमारे पास हाइपोनेट्रीमिया हो सकता है। डायबिटीज इंसिपिडस में डिहाइड्रेशन हो सकती है, SIADH में ओवरहाइड्रेशन। डायबिटीज इंसिपिडस में बॉडी लूजेस टू मच फ्लूइड, SIADH में बॉडी रिटेन्स टू मच फ्लूइड। ये एक दूसरे के तकरीबन ऑपोजिट आते हैं, both of them. Diabetes insipidus is a condition characterized by a large amount of dilute urine and increased thirst. Results from the deficiency of ADH, characterized by the passage of copious amount of dilute urine. The amount of urine produced can be nearly 20 liters per day. The types of diabetes insipidus are central diabetes insipidus and nephrogenic diabetes insipidus. The central diabetes insipidus occurs due to the failure of pituitary gland to secrete adequate ADH. And the nephrogenic diabetes insipidus results when the renal tubules of the kidney fail to respond to circulating ADH. The signs and symptoms of diabetes insipidus are polyuria, polydipsia, and thirst, nocturia or nocturnal enuresis, hyponatremic dehydration, anorexia, constipation, hyperthermia, and lack of sweating. सेंट्रल डायबिटीज इंसिपिडस में etiology में हमारे पास ट्यूमर्स हैं, इन्फेक्शंस, ट्रॉमा और ल्यूकीमिया है. इसमें आप देख सकते हैं सेंट्रल डायबिटीज इंसिपिडस में on the right side of the picture the ADH is not being produced by the pituitary. Nephrogenic diabetes insipidus की etiology में हमारे पास familial है, chronic pyelonephritis, hypokalemia, hypercalcemia, sickle cell disease, protein deprivation. इस पिक्चर के राइट साइड पे आप देख सकते हैं कि पिट्यूटरी से एडीएच सिक्रीट हो रहा है लेकिन किडनी पे वो जाके एक्ट नहीं कर रहा. Kidneys failed to respond to the ADH. ठीक है. All right. Now that we are done with diabetes insipidus and syndrome of inappropriate ADH secretion, this topic of hypothalamic and pituitary hormone is almost done. Almost क्योंकि इसके अंदर से जो मैंने ACTH वाला पोर्शन निकाला था वो अब हम आगे जाके कवर करेंगे एड्रिनल के अंदर. ठीक है. Do you have any questions up till now? Any questions, please? Questions? Well, I'm gonna move on. My next topic would be adrenal cortical hormones. जिस तरह के नाम से जाहिर है, adrenal cortex के hormones. The course curriculum of UHS